So I think it's great to have so many new options for patients with ALK-positive lung cancer. And I think crizotinib has been great for us, and this ability to sequence has been really wonderful. But when we look at the ALK-positive patient experience, or ALK-positive lung cancer patient experience, there are a couple of things that really emerge as important. So not only are we interested in, how long people are going to live and their progression-free survival and their response rate, which is correlated with their quality of life. Toxicity is important. How easy is it to take these medicines? But also, this population is at risk of brain metastasis. About a third of patients have it at baseline. Up to 70% develop it within 4 or 5 years. And so it's really, really important to try and start people on something that protects their brain. What's great about these next generation inhibitors is that they all have more activity than crizotinib. The challenge is, as they all move up into the first line setting, we have fewer targeted options later, and then the default then becomes chemotherapy or local therapy and continuing the same TKI. And I think that's a real challenge for clinicians and patients because we've gotten so used to having so many choices. But I do think, when we look at things, the tolerability, the efficacy, things like response and progression-free survival, and also the CNS activity are so important. And of course, in the public system, what you can access is key. If it's not funded for patients, we really can't access it, or through special programs. The only good side to that is it makes for really great clinical trial opportunities. And I really think that every ALK-positive patient should think about their trial opportunities. I think there's so much out there. The other interesting thing is, as we learn more about these new drugs and how some of them might be more active against certain resistance mutations than others, liquid biopsy can be a really effective and easier way to track changes in a patient's molecular resistance over time. So we know that drugs like lorlatinib are more active in patients with secondary ALK mutations at the time of resistance than if you don't have that, so an unknown mechanism of action. And again, it might help in future in terms of streaming. Probably it's not standard of care yet, but I think that in the very short term, it really will help guide us into who would be a good candidate for ongoing targeted therapy, who needs local therapy, and who needs chemotherapy.